Here's a question. Have you ever been prescribed a medication? Most likely, yes. Well, what about this question? Did you understand how it worked? The way your medication works in your body shouldn't be a mystery. Learn how Vyvgart, efgartigimod alpha FCAB works by visiting vyvgart.com/MOA. That's VYVGART.com/MOA. Brought to you by argenx.
From the American Academy of Neurology, I'm Dr. Daniel Correa. This is the Brain and Life Podcast. We are deep in summer. This episode, we're going to be including some activity and movement cues. We've heard from a lot of listeners that they like to listen to the podcast while going on a walk or doing their other physical activity. Shout out to my mom. And we would like to now include a few cues in some of our episodes for those who want to increase their activity levels or consider listening to the podcast during an activity. Recently this summer, in June, we just published a special issue of the Brain and Life magazine on Myasthenia Gravis, or MG. And our guest was featured in a section of the magazine that highlights community members. Ashley Brooks has been working to advocate for myasthenia gravis, to increase understanding about myasthenia, and reduce the stigma of living with this and other chronic diseases. In the coming weeks, you'll hear an interview with one of our guest hosts and the associate editor of the Brain and Life magazine, Dr. Sarah Song, who speaks with Dr. Roy Hamilton about agnosia. So a term I'm sure I've mentioned a few times now in lead-up and teasers for episodes, but you'll be hearing more about it and how we interpret the whole world around us. Next, you'll hear about the experiences of families who have a loved one with a rare epilepsy called SYNGAP1. So make sure to catch these upcoming episodes and not miss them by subscribing to this podcast wherever you're listening. Now, if you're in a place where you can get up for a walk or start an activity and you want to explore that with us, and if you haven't already started, join me and some of our walking listeners on a walk or your activity as we start with our interview. In the first few minutes of any activity, make sure to take it slow, listen to your body, warm up the muscles and joints. After the first 5 minutes of the episode, we'll take a quick break in to cue you to increase your activity level. Welcome back to the Brain and Life Podcast. Today I'm joined by Ashley Brooks. She not only works as a respiratory therapist and healthcare colleague, but also lives with myasthenia gravis, an autoimmune disorder that affects the chemical signals between the nerves and the muscles in the body. Since her diagnosis, she has dedicated her life to raising awareness about living with a rare disease and helping other people who are living with this same illness to find strength. Thank you, Ashley, for joining us here on the podcast today.
Hello, everybody, and thank you so much, Daniel, for having me today.
I wanted to hear a little bit more about your life and what were you doing back in 2017 before all this changed?
Yes, so let's go back to 2017. I was actually a junior in college. I attended Georgia State University, so I was downtown in the middle of the city, just basically trying to get ready to enter my career field. I was studying to become a respiratory therapist. So being like in the healthcare field, my senses are always like on 100. I'm always trying to see like, am I feeling okay? Like what's going on with myself? So I started noticing like little small things like at the beginning of the year, 2017, January, like my eyes at the end of the day, they would just be really, really low. I'd wake up in the morning and it would be gone. And we'd be like, okay, maybe we're just really, really tired or something. But that kept going on. And finally, around March, my birthday, we went out to eat and we got steak. You know, I love me a good steak. I had my steak medium. I could not chew my steak. And it was just really hard for me to chew and swallow my food. And I just started to notice, like at the end of my days, I was on the phone with my sisters talking and they could not understand me at all. So I finally broke down and went to the doctor and told them what was going on. And I told the doctor, you know, hey, like, these are my symptoms, and I'm in school for this. And we learned about this maybe a month ago, this disease called myasthenia gravis. But this is what I think I have. And they ran the tests, and sure enough, it came back that I had MG.
So from day one already, you had spent the time thinking about it, and you had an idea that what might be going on.
Yes, because the symptoms were so specific. The ptosis, the droopy eyelids, um, the slurred speech. It was very weird because in the morning when I woke up, everything would be back to normal. Like I would be back at my normal strength when I woke up, but then at the end of the day, I could not do much of anything. I couldn't walk up the stairs.
But it took a few months of having these symptoms and then learning about it in class and realizing, oh my gosh, these are my symptoms.
Also being like a 20-something-year-old busy in college, after I noticed the symptoms, I did go into the doctor. They had been calling me for, few weeks, months. After I went to the doctor in March, they've been calling me. They didn't get a hold of me until the end of April.
What were you doing that was making you so busy that you thought maybe you were just too tired from your schedule?
I was a junior, so when you're doing like healthcare, you have to do your clinical rotations. So on Tuesdays and Thursdays, I was in the hospital from 7 a.m. until like 4. And then I was still a full-time
Mm.
student. And I'm also was pledging to be in a sorority. I was working 2 jobs. I had my own organization, nonprofit organization I was running at the time. So I had quite a few things that I was dealing with. So yeah, I missed all of my doctor's phone calls. Yeah.
Okay, you were running things already.
Yeah. Pretty much. Yeah.
And what do you think held you back from just making those appointments? Just your schedule, or was there some already a sense of a little bit of worry and fear about having something and dealing with it?
I think more so I was just putting it off. Like the doctor seemed very concerned when she was going through my symptoms, and she was just like, "Oh no, we need to do all these tests and blood work." So it did freak me out a little. So when I left that appointment, I was kind of nervous, but she also told me, she's like, "Don't worry, you kind of are young to have MG." So I did leave the appointment thinking like, "Okay, well, you don't worry about it." And I kind of just put it like in the back of
Mm.
my mind. Yeah. I didn't want to deal with it, to be honest. Yeah.
And at this stage, you came in with the weakness that would come on after activity or fatigable weakness. Had you had any issues with breathing or respiratory distress?
So for me, I did not have any initially. It was more so my limbs, and even now to this day, my limbs and my muscles for talking, speaking,
Hmm.
chewing, swallowing, those were affected. I was choking on my spit, but I wasn't having
Oh, okay.
issues with like shortness of breath. Only time I noticed having respiratory issues was when like active myasthenic crisis is when I noticed respiratory issues.
Let's take a quick break and check in. If you're feeling good, feeling warmer, the joints are moving, then now would be a good time to try and increase your speed or your activity level. The total minutes of activity level for your brain health should be around an effort level where you're just a little out of breath. Could be hard to keep a conversation or finish a few sentences. Over the week, try and see if you can add up to 150 minutes of this type of activity. You can do this with just 20 minutes a day. If you do a walk or other activity during the full podcast, you'll already be nearly halfway to your weekly minimum goal. Right off the bat, when you started talking with your doctors about this diagnosis, did they talk to you some about respiratory and myasthenic crisis? And was that something that helped you understand it, or was that kind of shocking and concerning right early on?
So immediately after they did the blood work and it came back, positive for that, specific neurotransmitter receptor they're looking for, they referred me to a neurologist.
How was that discussion when you were starting, talking about initial treatments and with the options? I mean, because with myasthenia, like many other autoimmune conditions, there can be a lot of different initial options and a lot of side effects to consider.
Oh, for sure. I was really scared. Most autoimmune diseases, they start off with the steroids, the prednisone. And me, being that I was like in healthcare, I've seen my patients on steroids and see like the change in the weight, the appetite, and some of the other side effects with like their bones. So I was really scared. I told him, I was like, look, I don't want to be on steroids. But my neurologist was like, I mean, it's kind of necessary right now to get your symptoms managed. So my initial treatments was 60 milligrams of prednisone steroids, also another infusion medication called IVIG or immunoglobulin, Mestinon, and also azathioprine.
The steroids also help reduce some of the initial response and inflammation and the autoimmune process and hopefully get you over to some of the other medications. But yes, there's always the challenge of the side effect issues. And really, oftentimes, the other medicines hopefully help you reduce or get off those steroids and move to something else in the future.
Yeah.
And the mestinon you mentioned is that medication that tries to replace that chemical that's being depleted in your body.
Yes, I always refer to that as like my Band-Aid because it'll help me for my little momentary weakness, but not a cure.
And then you mentioned the azathioprine, that and some of the other medications are, yes, they were originally designed often as chemotherapy medications, but they're medicines that also help you reduce the dose of the steroid that you're on and help stop the autoimmune process or slow down the autoimmune process that's going on.
Yeah.
So that sounds like, you made the transition that is very similar to many other patients living with myasthenia. Each person's severity of illness is their own and it will be their own journey, but those are often a lot of the steps that need to be taken. Now, some people, they also get pictures taken of their chest to check out their thymus. Did you end up having that done? And how was that discussion with your doctor?
Yes, so they did another like chest x-ray to see if it was the thymus gland was enlarged. I didn't actually have any like it wasn't enlarged. I mean it was
Hmm.
probably like slightly, but because I was very adamant to like my doctors and my care team about I was 22 years old when I was diagnosed. I was kind of in my mind thinking long term about my medications
Hmm.
like I said I didn't want to be on the steroids and I wanted to eventually like have kids and just worrying about other things. So my doctors have kind of set up a plan with me so I could wean myself off of steroids, but it did include me having to get the open chest surgery, the thymectomy. They thought that if they were more aggressive and did remove my thymus, because they felt like that would help my immune system response.
Hmm.
So I did end up in December of 2017 getting my thymus removed. So they did a thymectomy. So I did get a sternotomy and plates in my chest.
It is a significant surgery, but it's an important one that sometimes it should be considered for people living with myasthenia. And we're going to make sure to go into a lot more detail to explain what that is and why it helps and for people in our medical expert portion of the interview. Tell us, Ashley, where are you now with your treatment and how do you consider yourself with the condition? Do you feel like you're cured? Are you in remission? Is it really more of a chronic management situation? How do you consider these terms that are out there?
Even though I do have good days, I don't consider myself to be in remission. I just think that my symptoms are more manageable and I have a better understanding of my limitation and my triggers now for my symptoms, my MG symptoms. So I'm able to live within like a certain means. So I don't aggravate them as much and I'm not like uncomfortable. Currently, I am no longer on the steroids. I no longer take mestinon. I am on a new treatment that's FDA approved, that's called Ultomiris. So I am on that, and I just had my 2 loading doses, so I can't tell you much, how, but, so far so good. I would say I've made some pretty good strides. I'm off the steroids, like, that was a goal at 2017, and I got off of them, and I only go back on them unless I'm, like, sick.
And this all came up while you were in college, as you say, like that time when we're all, there with peers, both having fun and aspiring to many goals. How did you deal with the mental health impact and the self-esteem impacts from the condition while you were in college? And what have you been doing to help manage it since?
Yeah, it was so overwhelming. The first thing I did was after I, got that call or we went in person, they were like, "This is what you have." I reached out to the mental health facility on campus at my school because I knew for a fact, like, okay, I can do this. I can go to the counseling facility, but they do like an intake where they have you speak to someone. And again, I was just really fortunate after I explained to the intake therapist what was going on and how it's just like I guess like having a pretty significant life change. They were able to get me in with a therapist twice a week until I graduated. I went through all the stages, grieving, yeah, denial. I went through that with my therapist. And I always recommend people when they're first newly diagnosed, you should just get some help, like mental health wise. It was everything. And I think because early on I reached out for help and was honest with myself.
I mean, that's great that you were able to connect so quickly to someone and then have that support through already what was an incredibly challenging time in your life with all the transitions and that you were working on. And then on top of that, to have a new chronic medical condition and diagnosis. We really encourage, especially with major changes in life, it's just getting involved and seeking support right off the bat, even if you're not noticing issues with depression, anxiety, or even just grieving. And you mentioned your website. So, in the course of getting your diagnosis, you started a blog and website with community information about myasthenia. But what information and messaging did you feel was missing when you were looking for this information?
Yeah, so when I typed in Myasthenia Gravis, like I understand it was rare, but I just would see general information like, oh, this is a rare disease, but I didn't see anyone who kind of looked like me. I didn't see like any black women who could like give me their experience. Like, okay, I see what the NIH says this is, or I see what WebMD says this is, just to understand what the disease is. But I wanted like a real person's perspective. I wanted to know like, are they still living life? Like, how are they functioning? But I could not find any information. And yeah, it was just very weird. So I thought like, let me create a website where I can make people aware, like, you would look at me and you would probably think like, "Oh, yeah, she doesn't have an autoimmune disease." But I think the beauty of it is like you can't really tell or look at someone and tell if they have an illness, a disability. I wanted that to be what the message was. I love makeup. I love, beauty related things, do reviews, but I also wanted to educate people on how it is for me, like a 20-something-year-old living with this rare condition. So people can maybe understand, have like more respect for it. I have an autoimmune disease. This is how life looks. So that's what the purpose of the website was. Like, you can still live, and this is how life could look, or it looks for me. I get emails from people all over the world. My friend from Romania, she's like, "I saw your website. I was just diagnosed, but seeing your website let me know that I could still live my life." That's everything to me because that was the goal. Like, you're still going to live your life.
Are there misconceptions that you found online that you felt like you just needed to address and explain further, and not only on how it relates to you, but for the community?
With MG, just in general, people don't understand. It's the physical manifestation of my limits, basically. A lot of people didn't understand, here's the blog and it outlines in a easy way, not a bunch of medical terms like layman's terms of how this disease affects my life and how it is, because it could be confusing for some people. They be like, the messages aren't communicating. And I'm like, if I move my hand too much, if I talk too long, my mouth would stop moving. My hand is going to stop. No matter how much I want to force my voluntary muscle to do something, it won't. And I wanted people to understand that because it was confusing even for my mom to get. It was like, I can't positively think my way or sheer willed make myself, it just will not.
What do you think changed in your goals and expectations for your life and for yourself?
I wanted to make money and have titles. I wanted to be respiratory therapist. Eventually, I was putting more emphasis on doing careers, jobs, whatever that are like within my means that aren't forcing me. Like when I was working as a respiratory therapist, I would push myself so hard. And that's, I believe, is partly why I spent a lot of my initial first years being diagnosed in the hospital so much and in the emergency room, ambulance rides, because I was still trying to get to the certain level, obtain this functionality. I was just making myself sicker. So now I put emphasis on, yeah, I would love a career that I enjoy, but I put more emphasis on being comfortable. So yeah, I'm putting emphasis on being comfortable, happy, Ashley, not, oh yeah, I'm out here doing this, that, and the third. And a lot of people I think are kind of focused on titles and being perceived by society to be super busy and productive.
Now we're back again for a quick activity check-in. If you're on a walk, jog, bike ride, we are at the halfway point now. If it's right for you, it might be time to turn around and start your way back. If you are planning an activity as a one-way trip to the grocery store or another destination, then let's keep going. So you're present now and taking care of yourself.
Yes.
Now, I want to go back though then to the day you were diagnosed. What advice or support would you give to yourself or to someone else, or maybe even to your mother or a family member of someone diagnosed at that time?
I would just probably say just give yourself some grace. And then that sounds cliche, but it's something I always have to remind myself, like giving yourself grace, being honest with yourself about your limitations, your boundaries. It's okay to say no. You can cut yourself some slack and just listen to your body. That's going to be a big one. Listening to your body and being honest with yourself. Yeah, it took me a while.
And is there any way that you feel like it's important that family members and friends help support someone who lives with MG?
Oh yeah, I would say your support system is everything. I have a pretty solid one. My mom and my sister, they are just like a sounding board of reminding me when I'm doing too much, my boundaries. I know I'm may seem like I can able to advocate for myself, but sometimes I do, have a tough time if I'm in the presence of my doctor or nurse. It gets intimidating. Even if I'm a person in like healthcare, it's sometimes hard to speak up for yourself, but your support system, that's what they're there for.
Well, Ashley, I want to honor and thank you for spending your time and energy with us today. I know it's precious, especially for you.
Yes, yes, yes. No, absolutely. It was my pleasure. Thank you so much.
Is this episode leaving you wanting more? Get the latest tips on healthy living and management for more than 250 neurologic conditions by visiting brainandlife.org, where you can learn more about neurology every day, powered by trusted neurologists. Welcome back to the Brain and Life podcast. So now, after that discussion with Ashley Brooks, I'm joined by Dr. Gordon Smith, a professor and chair of neurology at Virginia Commonwealth University. He's an internationally recognized expert in the diagnosis and treatment of nerve and muscle disorders, and he's been a leader in multiple clinical research trials for various nerve disorders. Today, we are talking with Gordon about supporting the quality of life of people living with myasthenia gravis and some of the new treatments. Thank you so much for taking the time to join us.
Daniel, I'm very excited for the invitation and to be able to talk with you today.
In our past episode with Suzanne Rogers and our expert discussion with Dr. Nicholas Silvestri, we heard some about the basics about what is myasthenia, but can you recap for us how you explain myasthenia gravis to other people who are new to the condition?
Sure, Daniel. It's kind of a complicated thing to explain. So I'll go through how I try to make this digestible. So myasthenia gravis is an autoimmune disorder. And so this is a disorder where your immune system gets confused, and rather than attacking a foreign invader, a virus or a bacteria, attacks your body. And in this case, it attacks the receptors on the muscle membrane that receive the nerve signal that triggers movement. And I think of the metaphor of satellite television. I used to live up in the mountains and had a satellite dish. And the way the nerve communicates to the muscle is by releasing a chemical called acetylcholine that floats over and binds to essentially like a satellite dish on the surface of the muscle. And so when this happens, a couple of things occur. One, the signal can't get through because it's being blocked by this antibody. And so that would be like having snow in your satellite dish. The signal doesn't get through. The other thing that happens is the antibodies that your body makes against the acetylcholine receptor, that satellite dish on the muscle, actually triggers damage. And I'm sure we'll talk more about how that occurs because it informs the new therapies we have, which are very exciting. But this would be the equivalent of not only snow in your satellite dish, but someone ripping the satellite dish off the roof of your house and actually poking a hole in your roof. And so this obviously causes muscle weakness, and it causes a lot of fatigue for patients. And the thing that I think is particularly perplexing is the variability in symptoms between different patients with myasthenia gravis. Most patients initially will have weakness in eye muscles, so drooping eyelids or double vision. But most patients, probably 60%, over a couple of years will progress to have weakness of other muscles, and that can be speech and swallowing, so slurred speech or choking on foods, or weakness in their limb muscles, trouble working over their head or walking, or even difficulty with breathing.
When Ashley was in college, she was at that time starting to learn and start her initial training as a respiratory therapist, working hard, multiple jobs. Initially her symptoms started. She had some of that fatigue and occasionally would have some episodes of blurred vision or double vision. She explained it away, of course, because she was working so hard and not sleeping well. And initially, when she really started to have the more significant symptoms, it was unique that it was only a few weeks after her first course where she learned about myasthenia and almost started that diagnosis on herself. And so her symptoms included double vision, blurred vision, a weakened smile, slurred speech, and eventually some right facial droop. But as you talked about, there's lots of other symptoms that come along with myasthenia. What is it beyond weakness that many people live with?
Well, the fatigue is important, and as neurologists, Daniel, we're taught that fatigue in myasthenia gravis is fatigability. In other words, the phenomena where with repeated movement of a muscle, it becomes weaker. That kind of fatigue patients appreciate as weakness, but it's also common that patients with myasthenia gravis have true fatigue, just exhaustion associated with their disease. And then there are other aspects to this that can be particularly troublesome. For instance, many patients have a great deal of difficulty tolerating heat. There are reasons for that biologically, but the fatigue can be much worse, and the heat and the ability to get things done in the heat can be problematic. It's actually the only condition where I've ever written a prescription for an air conditioner in my career.
Ashley, when she was learning and was already working in a respiratory therapy program, when she started to have symptoms and had some awareness of what might be going on, she luckily was able to get to a neurologist and to get to more diagnostic and early treatment very quickly. But it seems like that's not necessarily the case for everyone who has symptoms that might be myasthenia or eventually diagnosed as myasthenia. What is the usual or typical delayed diagnosis that we have seen, and what are some of the problems with that?
Yeah, Daniel, that's a great question. And I think in some ways this is similar to giving prognostic information to patients. I think the average experience isn't particularly helpful
Mm.
because there's a broad spectrum, right? Some patients who are medical professionals, as is the case with Ashley, get to a diagnosis fairly rapidly, but others have a significant delay. And there is a lot of diversity in this, and I think a lot of care disparities. I work in Richmond, Virginia, which is a very diverse community. I moved from Utah, and one of the things I observed coming here is the impact of care disparities, and by that I mean not only urban populations, but we care for a large rural population that often has difficulty accessing care. And even when patients are able to access care, they sometimes don't have access to subspecialists or even neurologists. As you know, there are not as many neurologists as we need. And so there's a lot of variability. Some patients get diagnosed quickly, but for some it takes a long time. And even after diagnosis, to get the appropriate care can be a real challenge.
And Ashley shared with us that early on she was placed on steroids and then started on azathioprine before moving on to some other newer medications. Can you explain for our listeners some of the differences between emergency or crisis treatment and more long term treatments for myasthenia?
Sure, Daniel. And I think that's a question that's becoming more complicated in a good way because we have all of these new treatments, and trying to figure out where they should be applied is an active area of investigation and discussion. Traditionally, chronic management of myasthenia has been focused on use of medicine that helps boost the signal in between the nerve and the muscle. So mestinon or pyridostigmine, which blocks the breakdown of that chemical signal. That's helpful for many patients, but for most, it's not enough. After that, we've traditionally relied on prednisone or steroids, which work for most patients. They're very effective, actually. But the challenge is there are a lot of side effects, and I suspect Ashley may have commented a bit about these as well. It's hard for patients to take prednisone. Uh, the approach we typically take with prednisone is to gradually decrease the dose over time to minimize those side effects. Oftentimes, it's difficult to get to a low enough dose that is both effective and doesn't have side effects. And for that reason, we typically have used medicines like azathioprine, or another common one is mycophenolate mofetil. These are drugs that are commonly used to prevent organ transplant rejection or in other immune diseases. In this context, we call them steroid-sparing agents. They help people reduce steroid doses. But these medicines have their own side effects and risks and require monitoring. And so while that approach works really well, it has problems, particularly in terms of medication side effects. For acute treatments, for patients who are in a crisis, perhaps in an intensive care unit or in the hospital, the two approaches that we've typically used are something called plasma exchange, which is often described as a dialysis type treatment. That's not really how it works, but it's kind of a construct that works to explain it. It basically gets rid of the antibodies in the blood, and this is a treatment that requires a large IV catheter, a central line, that is similar to those that are used for dialysis, and is done about every other day. Usually we use maybe 3, 4, 5 of these treatments. The other is infusion of immunoglobulin or intravenous immunoglobulin, IVIG. Both of those are effective in treating patients who have a crisis. Occasionally, we use them chronically. In particular, IVIG can be used to either bridge patients from a crisis situation into their maintenance therapy, or sometimes we'll use it as a chronic therapy for patients who really can't be taking steroids. And of course, we'll talk more in a moment, Daniel, I'm sure, about the new agents which are really transforming care. But this overall treatment approach is good. And in fact, probably 80-90% of patients do well on that from a medical perspective. Like the doctors will say, gosh, my patient's doing really well. But if you ask patients, many, probably more often than not, are unsatisfied. In other words, maybe their myasthenia gravis is under good control by the neurologist's perspective, but they may have side effects from the medicines they're taking. And I think that's the promise of the new therapies, is really to not only provide a higher level of disease control, but to do so in a way we hope that will leave patients with fewer side effects.
I wanted to remind our listeners, as Gordon brought up, there is this term of crisis or attacks in myasthenia. Please listen to our past episode with Susanna Rogers and our expert, Dr. Silvestri, where we talk about and explain what the crisis or attacks are in myasthenia. So Gordon, tell us, where have we gotten with these new medications, and how are they different from the past medicines that we use for management of myasthenia?
Well, Daniel, they're more targeted. So if you think about the treatment approach I described with steroids or IVIG and plasma exchange, there are a couple of things that I didn't say, which is precisely how they help. Now, the plasma exchange gets rid of antibodies, so that kind of makes sense. But steroid-sparing agents, and IVIG are probably pretty blunt tools. They're messy in that they have lots of different mechanisms. The two classes of medications that are now available to us are more targeted. And so the one class that was first approved are complement inhibitors. So these are Soliris or Ultomiris or eculizumab or ravulizumab. Complement is the way that the immune system rips the antenna off your roof and pokes holes in it. So complement's a really confusing system, but it's this network of proteins that ultimately lead to a number of different activities in the immune system. And this is obviously the way your immune system gets rid of bacteria, for instance. One aspect is they attract a whole bunch of chemicals that increase inflammation, but the pointy end of the stick, as it were, no pun intended, is that it ends up poking holes in cells and causing the cells to be damaged. And so this turns out to be a really important mechanism by which these antibodies that cause myasthenia gravis, particularly the acetylcholine receptor antibodies, it's important to recognize that there are patients who have different antibodies for which complement may not be important. But for the 85-90% of patients who have these acetylcholine receptor antibodies, complement's the way that muscle membrane is damaged. And so the eculizumab, Soliris, ravulizumab, Ultomiris treat that mechanism. And there are others in development that we might talk about. The other new class of agents is exemplified by Vyvgart. The non-trade name is efgartigimod. So Vyvgart's easier to say. Vyvgart is another way of getting rid of antibodies that uses a system called the FcRn system, which is a pretty cool system. I don't know if you've ever thought about this, but how do antibodies get across the placenta from the maternal circulation into the fetal circulation? Or how do babies get antibodies into their blood from mother's milk? And it's this system, right? And this system is not only important for fetal and neonatal antibody regulation, but it's also a mechanism by which our body regulates antibody levels. And so inhibiting this system basically forces the cells in your body to get rid of antibodies. And so you can think of it as a more targeted plasma exchange, but it's an infusion, which means it's a lot easier to use. And so these two different classes of medicines both work very well. It appears 60 to 70% of patients respond, keeping in mind in clinical trials, there's always 30% or so of patients who get the placebo get better too. But they're very effective, and they seem so far to be well tolerated. There's some nuances to each that we might talk about. But these, I think, promise to transform care in a lot of ways. One is it gives us other treatment options. Two, we can think of creative ways that we might use them. For instance, maybe these can be used in acute settings. They certainly can be used to treat patients who have intolerable side effects from prednisone or other medicines.
And then to follow that up with another treatment that is used and increasingly used, but isn't necessarily another medicine. So Ashley also had a thymectomy. When and why are you discussing a thymectomy with patients living with myasthenia?
It's a question for which now we have better answers than we used to. We've known for a long time that the thymus gland is important in myasthenia. Some patients with myasthenia gravis have a tumor in their thymus gland that needs to come out. But what's more, we thought for a long time that taking out the thymus gland in people who have myasthenia gravis, even if they don't have a thymoma or a tumor in the thymus gland, may help with long-term control. But there wasn't really good data to guide us in this, and it was variable whether patients got this or not. We now have good data from a very large clinical trial that demonstrate that taking out the thymus gland in younger patients early in the disease can be helpful or is helpful in reducing the disease severity over time and allowing patients to get onto lower doses of prednisone, which, as we've talked about, is really important because prednisone causes a lot of side effects for patients. And so for younger patients early in the disease, we recommend a thymectomy or being evaluated for a thymectomy. Older patients, those who've had the disease for a long time on multiple treatments, probably not as good a candidate. There's still a lot of questions that are out there, and I'll throw one that I think our listeners may be particularly interested in, and that is how do we treat ocular myasthenia? As a neurologist, I was always trained that ocular myasthenia is sort of mild myasthenia, right? And even if you look at the MGFA, Myasthenia Gravis Foundation of America classification system, the mildest form is ocular alone. But when you talk to patients, ocular symptoms are very disabling to them. And, as a community, there's been discussion about how nice it would be to have data regarding whether thymectomy would work in patients who have significant ocular-only disease. So we'll need to await further clinical trials for that. But for now, at least, we've got a pretty clear answer that thymectomy in the right patient population is both appropriate and effective.
Thank you, Dr. Gordon-Smith, for taking the time to join with us and speak with our listeners about your perspective and treating a community with myasthenia.
Well, thank you, Daniel. I appreciate all you do with the Brain and Life podcast. It's a great resource for our community.
Thanks for listening to the podcast throughout your weekly activities. And I hope our activity cues today were helpful as you think about how to increase your activity time each week to help with brain health and move better with your abilities. Thank you again for joining us today on the Brain and Life podcast. Follow and subscribe to this podcast so you don't miss our weekly episodes. You can also sign up to receive the Brain and Life magazine for free at brainandlife.org and even get the Espanol version. For each episode, you can find out how to connect with our team and our guests, along with great resources in our show notes. We love it when we hear your ideas or questions. You can send these in by email to blpodcast@brainandlife.org and leave us a message at 612-928-6206. You can also follow the Brain and Life magazine and me on any of your preferred social media channels. These episodes would not be possible without the Brain and Life podcast team, including Nicole Lucier, our Public Engagement Program Manager, Rachel Coleman, our Public Engagement Coordinator, and Twin City Sound, our audio editing partner. I'm your host, Dr. Daniel Correa, connecting with you from New York City and online at NeuroDr. Correa. Most importantly, thanks to our community members that trust us with their health and everyone living with neurologic conditions. We hope together we can take steps to better brain health and each thrive with our own abilities every day. Before you start the next episode, we would appreciate it if you could give us 5 stars and leave a review. This helps others find the Brain and Life podcast. See you next week.